So thank you for inviting me. So in our cohort of infants who received antibiotics in the first 6 months of life, allergic disease later in childhood was common. It was found in 30% of the population. The key point is that within these antibiotic-exposed infants, we didn't see meaningful differences in later allergy based on which antibiotic class was used or how many classes were given. Because we didn't include a no antibiotic control group, we can't quantify how much risk is attributable to antibiotic versus other factors. But other studies that assess the same cohorts, some of them assess the dose given. So they found actually that with increased dose, there is more risk of allergy. So the absence of a class-specific signal suggests that within the antibiotic-exposed infants, we couldn't identify one common antibiotic class that consistently increased or decreased later allergy risk, which is consistent with most previous studies indicating no class-specific association, but there was a general association between antibiotics and allergy in those studies. Also, there was some other studies that assessed the dose of antibiotics that was used, as we said before. It was a factor in increasing allergies. So clinicians should continue choosing antibiotics based on the infection, safety profile, and guidelines, while avoiding any unnecessary antibiotic administration or a prolonged exposure too, if it can be avoided. Yeah, so we mostly reinforce it, as antibiotics can affect the microbiome in early life, and this remains a valid concern with a good level of evidence now. It's currently, there's emerging evidence too. But what our study adds is that among infants who did receive antibiotics, later allergy rates did not meaningfully differ by class or number of classes. But as we said, some studies showed that the dose increasing dose was related to increased allergy. That points away from simplistic specific antibiotic causing allergy narratives and back towards careful evidence-based antibiotic use. Also, recent studies assessing asthmatic patients showed improvement with probiotics, although it didn't lead to completely resolving the disease. A similar pattern was also seen in multiple sclerosis patients. So the microbiome immune axis is a rapidly developing field in the recent years, and I think there is much more to that axis than we know now. Yeah, so we should always tell parents if antibiotics are truly needed, treating the infection is a priority. But our study looked at infants who received antibiotics, and within that group, later allergy didn't depend on the antibiotic class or number of classes. So we didn't have a no antibiotic control group to compare it to. But the practical approach is clear. Use antibiotics when indicated, avoid them when not, and keep courses as targeted and short as safely possible. And there have been some studies assessing shorter duration for common diseases that require antibiotics. And some of them actually showed that shorter duration can be just as good as the prolonged durations. Yeah, so in our data, the number of different antibiotic classes didn't predict later allergy among antibiotic-exposed infants, but we didn't measure dose or duration. And other studies suggest more exposure may relate to higher risk of allergy, but most studies had some confounding. So stewardship remains essential, avoiding unnecessary antibiotics and keeping treatment appropriately targeted. And we look for further studies in that field. But the main takeaway was emphasizing stewardship. As in many developing countries, antibiotics are commonly used for viral infections. Sometimes it's a physician error and sometimes patient error. For example, like here in Palestine, antibiotics are over-the-counter medications, so practically anyone can get them. And it's common sometimes for patients to get them at the first day of a viral infection, just as soon as they're having some coughs or a sore throat. But also at the same time, even in the US, we have seen some touring entertainers and artists actually get antibiotic prescribed over a 1-minute phone call without any clinical indications. So yeah, it remains a universal problem, I think. And there should be more accountability universally for antibiotic stewardship. Yeah, so we saw a small signal suggesting lower allergy odds with trimethoprim-sulfamethoxazole. But because this exposure was uncommon and the study is observational, it's not practice changing. It's best viewed as a research signal to test a larger prospective data set. There is some research of it as a anti-tumor effect in melanoma patients. So there is more to that antibiotic than we know, and I hope more studies study those effects too. Yeah, I think they should be very cautious actually. So as we said, a single subgroup signal in a retrospective study shouldn't change prescribing, but it's a starting point for future research. So yeah, 30% might sound high, but prevalence estimates vary a lot depending on how allergic disease is identified and how it's measured. For example, US surveys looking at the diagnosis of allergic conditions can approach the high 20% range, sometimes reaching 30%. So the key point in our cohort was specifically infants exposed to antibiotics. So it's not a community prevalence estimate and shouldn't be compared directly across regions. We don't have any estimates of allergic prevalence in the region. And even worldwide, most studies are shallow. There is not enough data on that topic. Yeah, so this retrospective design, so yeah, it was retrospective and we lacked no antibiotic control group. So we can't make casual claims about antibiotics versus no antibiotics. We also didn't capture dose and duration, which is key in other studies because those was related to more allergy. And we also infection-related confounding may always play a challenge in those patients. Yes, so we need the prospective studies starting at birth that include infants who did and did not receive antibiotics. I don't think RCTs are feasible for such an idea because we can't expose patients that don't need antibiotics to them. But I think studies should capture why antibiotics were prescribed and measure the dose and duration. And then maybe an extra level of detail can be made from those studies to separate antibiotic effects from the effect of early infection too.